Hi, thank you everybody for joining me in this quick case discussion about lysozyme nephropathy. This video is in partnership with the International Society of Nephrology and the American Society of Onconephrology. So first we'll start with our case. This is a 70-year-old gentleman, otherwise healthy, no real medical history. 4 years ago, he actually was diagnosed with chronic myelomonocytic leukemia. Basically, his platelet count was in the low 100s and he was referred to hematology. His white blood count at that time was 16.9 and his absolute monocyte count was 8.1. He did have a bone marrow biopsy at that time. It showed no blasts, and he was otherwise asymptomatic, and so hematology just recommended routine surveillance and monitoring. At that time, his serum creatinine was 1.8, and he did have a urine dipstick that was positive for protein, but no other evaluation was done. Of note, a year ago, his creatinine was actually 1. 2 years later, he was in and out of the hospital with recurrent kidney stones, uric acid composition, and repeat AKIs. They were bilateral kidney stones. His creatinine would peak up to 3.3 and then nadir down to around 1.9. And so because of that, no further intervention was done, except somebody at some point in time did a spot urine protein to creatinine ratio that showed he had around 1 gram of protein. But unfortunately, his kidney function continued to decline. So over the next year, his creatinine slowly crept up to around 2.5, sometimes 2.9, and then would come down with intermittent hydration. His white blood count was 28.2. And at that time, a 24-hour urine protein was collected, and it did show 2 grams of protein in the urine at that time. He did a repeat bone marrow biopsy that showed 8% blasts, and there was some concern that, maybe he would benefit from therapy, especially given his renal decline. So he was actually started on hydroxyurea, but after 3 months of therapy, there was no change in his renal function. His white count did come down, but it was actually the therapy was discontinued because his platelet count dropped to around 34,000. 6 months after starting the hydroxyurea, so again, 3 months on therapy and then 3 months off of therapy, he had a repeat bone marrow biopsy. His white count had increased to 47.6, and the repeat biopsy at that time showed 95% cellularity with megakaryocytic dysplasia, and he had 10 to 50% blasts. A serum lysozyme level was performed at that time, and the level was more than 10.8 micrograms per deciliter. His serum creatinine was actually overall stable as 2.6. And so based off of everything, actually a kidney biopsy was performed, especially with the persistent chronic kidney disease and the proteinuria. So this is his kidney biopsy. This is the H&E. If you can see, pretty remarkably, his tubules, the proximal tubules, are pretty swollen and congested. A lot of cellularity between the cells. Tubules up top tend to be back to back, so not a ton of interstitial inflammation. This is the PAS, so again, you can note the tubules are pretty swollen. This section of the glomerulus looks pretty good. Mild hypercellularity. The trichome stain didn't look too bad, not a lot of scarring. And this is the silver stain. So the kidney biopsy was actually read as proximal tubulopathy, suspicious for lysozyme-induced nephropathy. The reason why they said suspicious is because the lysozyme stain was only weakly positive instead of strongly positive. Our pathologist said it's because the lysozyme stain is actually optimized for hematologic tissue, and so that may partly be why. But the presence or absence of a stain does not determine the diagnosis. It's mostly a clinical diagnosis. Having high serum lysozyme levels and high urine lysozyme levels cinches the diagnosis. Surprisingly, despite him having an elevated creatinine for quite a while, he only had a pretty minimal amount of tubular atrophy and interstitial fibrosis, and about a third of his glomeruli had global glomerulosclerosis. So a little bit about CMML and lysozyme nephropathy. CMML is a pretty rare, it is an aggressive blood cancer, typically found in patients over 65 years old, and is characterized by peripheral blood monocytes with mild dysplastic features. And the interesting thing about monocytes is they actually create an enzyme called lysozyme. So lysozyme, sometimes called neuraminidase, is actually a lytic enzyme that's secreted by monocytes, and these help to um, fight the bacteria by damaging their cell walls. And so it is the interesting thing about lysozyme 2 is that it's actually freely filtered. It's reabsorbed in the proximal tubule, so that's why you get a lot of proximal tubule abnormalities, and it can stain really strongly for lysozyme. So this is a case report by Santoriello in the Kidney International Reports in 2017, where their kidney biopsy did stain really strongly for lysozyme. It can lead to a range of acute kidney injury and also different ranges of proteinuria. So presumably this would be tubular proteinuria rather than albumin predominant. In our patient, a urine albumin was never collected. And the characteristic finding on renal pathology is tubular injury with granular inclusions that do stain positive for lysozyme. There was a really nice recent Kidney International Reports case series by Kudos et al. In 2023 that looked at all patients with lysozyme nephropathy in their institution and uh, case reports. Of the 37 patients that they described, the median age was 74 years old. 78% of them were male. At the time of biopsy, all patients had acute kidney injury, and their mean GFR was around 21, and they had proteinuria with a mean proteinuria of 0.7 grams. Despite having pretty significant proximal tubule abnormality, only 15% of them had a partial Fanconi syndrome. And biopsy uniformly showed proximal tubulopathy with hypereosinophilic intracytoplasmic inclusions and staining positive for lysozyme. And they looked at the associated disorders associated with lysozyme nephropathy. The majority of patients had chronic myelomonocytic leukemia. Some patients did have AML and myelodysplastic syndrome. Hematologic malignancies tend to be the most prominent disorder. However, non-hematologic malignancies were seen as well. A couple of cases of metastatic neuroendocrine carcinoma, and interestingly, it was seen in 2 patients who did not have any malignancy at all, but kind of a chronic inflammatory state, sarcoidosis and leprosy. Probably these diseases activated the innate immunity and high monocyte activation. In general, what they found is these patients unfortunately have a really high mortality. So at the time of writing the manuscript, 22 patients were alive, and only 85% of them had therapy for their underlying disease. 7 of those patients did improve kidney function. 1 actually improved to the point of being able to discontinue their dialysis. And the other 6 actually had a pretty significant increase in their estimated GFR by more than 15 milliliters per minute compared to the time of biopsy. Our patient, unfortunately, did not have such a robust response. So after the kidney biopsy, shortly thereafter, he was found to have progressed to AMML and continued to decline. Interestingly, in the last month of his life, his repeat urinalysis started to become positive for glucose in the urine. He had no history of hyperglycemia or diabetes, and he died a few weeks later. So a few discussion points. So lysozyme nephropathy is a very rare cause of AKI and CMML. It can develop proteinuria, probably more tubular rather than albumin proteinuria. It does have a high mortality with an overall poor outcome, but the series from Kudos et al. Does suggest that maybe early detection may lead to earlier treatment, and there may be actually improved renal function in these patients and overall disease modification. So something to keep in mind in our patients. We don't often check lysozyme levels, but anybody with any abnormality or unexplained proteinuria probably deserves a kidney biopsy in this setting, especially if they're not already on therapy.